Good afternoon. Welcome, and thank you for joining this, our latest webinar in our series exploring longevity in the post-COVID world. This is a specially extended webinar where we'll be taking stock of the thoughts and ideas that we've been discussing through the series so far to consider the key issues informing an expectation of mortality improvement over the next 20 years. I'm delighted to have joining me to discuss these topics, hopefully, Matthew Edwards, although he may be a little bit late, Daniel Ryan, Chris Martin, and Richard Willets. I'll just briefly introduce these four. Give me a moment. I will find my bio so I make sure I don't completely mislead this. So Matthew leads the mortality, longevity, and life analytics work in Willis Towers Watson's life practice. He is currently the chair of the CMI, co-chair / co-founder of the COVID-19 Actuaries Response Group, and editor of the IFWA's Longevity Bulletin. He is apparently speaking here in a personal capacity and not expressing the views of any of these entities. Daniel is a medical biodemographer with 3 decades of experience in the insurance industry. He led a global multidisciplinary research teams at Swiss Re and Willis Towers Watson in diverse areas including forward-looking risk models and behavioural science. Throughout the pandemic, he was a member of the COVID-19 Actuaries Response Group, writing on epidemiology, medical advances, care homes, and was previously a key contributor to the development of the Pandemic Emergency Facility with the Institute of Medicine, World Health Organization, and World Bank. Chris is a former general practitioner and health informatician with an MSc and PhD from the Centre for Health Informatics and Multi-Professional Education at University College London. He has specialised in cause of death and risk-based mortality and longevity modelling to support healthcare decision-making at the clinical and policy level for over 20 years and has worked in the pensions and insurance industry since 2008. He is a fellow and former council member of the Royal College of General Practitioners and is a former chairman of the Essex faculty of the RCGP and the Essex Primary Care Research Network. He's co-founder of Crystallise, which provides medical modelling, advice and software to the finance, healthcare and pharmaceutical industries. Chris leads the modelling team on developing a range of cause of death, mortality and clinical models. And last but not least, Richard has specialised in longevity research since the 1990s when he wrote the prize-winning paper Mortality in the Next Millennium. He's a former member of the CMI Executive Committee and chaired the Mortality Projections Working Party when he originally developed the CMI projections model. Richard now works for Just Group as an expert longevity consultant. So we've got a good range of panelists to share their thoughts today. Just going to begin by sort of briefly outlining the structure of the webinar. So the first half of the webinar will be taken where each of our experts will be discussing a specific topic. Matthew will be talking about how we can use a time frame methodology for considering mortality improvements. Dan will be discussing endemic and future COVID. Chris will be providing his perspective on the state of medical and technical advances, and Richard will be talking through a real-world example of how to bring considerations of longevity catalysts together to form an expectation. In the second half of the webinar, we'll be discussing possible scenarios for mortality improvement over the next 20 years and asking the panelists for their views on the relative likelihood of some alternative outcomes. As we're going through, if any questions arise, please add them to the chat. We have got hopefully sufficient time at the end to discuss these. But if it's okay, I'd like to sort of begin by recapping the story so far. The COVID-19 pandemic has probably been the most significant longevity event in our lifetime. There have obviously been the significant effects on individual specific mortality and health issues, as well as the larger and social political challenges. But in addition, the pandemic has profoundly impacted the challenging for us as practitioners of assessing future longevity. Whilst best practice for longevity practitioners has been to utilise more expectation-based approaches, there has remained a reliance upon modelling of observed data. And with the current necessary data being significantly disrupted or not yet available, we've all had to lean more heavily on interpreting information to form those expectations than we have done in the past, or ideally would like to. The pandemic, if we consider it holistically, has had and continues to have the potential to materially affect a number of longevity catalysts, ranging from the personal health circumstances, through medical innovation and delivery, to social and political behaviour. And in the absence of the desired data and information, we have become more reliant on our ability to interpret signals from noise and the challenging of not allowing our own cognitive biases from unduly affecting our conclusions. This challenge is, in our view, likely to remain for some time. And one of the reasons for setting up these webinars was to aid practitioners through this webinar series such that we can explore a range of topics. And just as a reminder of what those topics were, in our very first webinar over a year ago, we discussed the challenges we faced and considered the longevity signals we should be looking out for and how we might distinguish these from mere noise. We've discussed how we should consider the data that's emerging from the pandemic and utilize this data in setting assumptions. We've discussed the provision of social care, which was a challenge before the pandemic, and with an increasing number of people surviving to older ages, remains and is becoming an increasingly more important consideration that we need to make. We have observed during the pandemic a reduced number of people being diagnosed with cancer. In one of our webinars earlier this year, we had a really interesting discussion exploring this issue. Prior to the pandemic, the effects of austerity have demonstrated that fiscal, economic and political issues can have quite direct and immediate impacts upon mortality improvement. And one of our most recent webinars discussed the potential impact of the changing economic circumstances in the globe generally and the UK specifically going forward. And our most recent webinar discussed the apparent number of excess deaths over the summer and the implications on current levels of mortality and mortality improvement in the future. We hope that you found these past webinars useful, and they do remain available on our website if people haven't watched them or would like to rewatch them if they're so inclined. So I would like at this stage to bring in Matthew, but I'm not sure whether he's been able to join yet. He may be joining us shortly. So I'm going to skip over Matthew and I will bring in Dan. And Dan will be talking about endemic and future COVID. So Dan, over to you.
I think you're on mute, Dan.
Oh.
Thank you very much. I appreciate that. So too many buttons. So as I was saying, here we are looking at a graph or a slide that we all know very well, but it continues to evolve and evolve in a worrying way during 2022. So here we have the black line, which shows the comparison versus 2019. And since the first half of the year, when everything looked like it was progressing very well, we have this continuing deterioration in the mortality, and hence the consideration of endemic and future COVID. And when I say that, I mean not just the direct effects of COVID, but some of the indirect effects of COVID as well, which we will come on to. And one thing that we've become increasingly commonly aware of is that whilst in the early days, a few Greek letters was sufficient to describe where we were, now we have increasingly more and more suffixes. And this rather complicated slide from the UK HSA shows quite how diverse the variants have become. And those that we're particularly interested in at the moment, the BQ11 and the BQ1 and the XBB, these are variants which have over time developed an amazing ability to escape the immune response, because that's effectively how they continue to survive and thrive. But it means that we have to be increasingly aware with each new evolution. What does this mean in terms of the possible virulence? And so far with Omicron, we are relatively fortunate in that this is a disease which largely focuses on the upper respiratory tract, breeds quickly and then gets communicated or transmitted quickly without involving some of the more serious consequences for a wider group of the people that we see with Delta. But constantly being aware of the fact that we have this even as you drive, leading to new variants. And so the real question is, how is COVID now and over the short term, others will talk about the longer term, how is it really going to impact our health and mortality? And I wanted to kind of highlight maybe a few different areas, and we'll probably spend more time talking about later on. First of all, long COVID. It's a very general term. I'm going to spend a bit of time on that later. But there's a whole variety of behavioral and structural changes that COVID is effectively causing. First of all, this disconnect that's developing between individuals and their health, less attendance at annual checks, less attendance at screenings. Some people have become much more in terms of their exercise regime, but others have given up. And then the increasing difficulty in terms of accessing healthcare services, and indeed for healthcare professionals actually providing those services. And what we have seen is that over the last months, years, an increasing understanding of not just the immediate effects of COVID in terms of mortality, but studies that have started to look at these longer term effects. Just in this last month, not only do we have the latest update from the ONS COVID study in terms of the prevalence of long COVID across the population and those that are affected either not much or to a very great deal, but also studies coming from the US veterans looking at the importance of understanding reinfection and how that leads to additional long-term mortality. And study from Discovery in South Africa highlighting the additional number of deaths, particularly cardiovascular deaths, that they're seeing in their portfolios, and from long cohorts such as the one in Estonia, looking at the additional mortality over time. So whilst increasing evidence becomes apparent, it is also clear that the long COVID effect, it will be affecting a minority of the population. And the difficulty will be identifying whether individuals genuinely do have continuing effects from COVID and whether they are due to microclots, whether they're due to immune disturbances, or whether they're due to other interactions with the COVID virus. But I wanted to just highlight also these longer term effects in terms of how COVID has disrupted healthcare services and what that really means for us when it comes to making assumptions for the future. And the first and most important one I wanted to share was just in terms of the delays that started as soon as the COVID pandemic began, with operations being cancelled and diagnostic tests being delayed. And so here on the left-hand side is an expression of the numbers of diagnostic tests that have been delayed by 6 weeks or more. And here on the right is those that were delayed by 13 weeks or more. And the reference throughout is 1%. 1% is the target level the NHS was aiming for. And you can see with the red lines which relate to October 2020, that initial outbreak, the lockdowns that followed, led to a huge delay. That the worrying piece for us is that whilst there has been some recovery, for many of these, the recovery has not been very significant. And indeed, in 2022, we actually see some of these darker blue lines actually being higher than they were in 21. So we are getting more delayed in terms of diagnostic tests. And whilst the number of cancelled operations is not too dissimilar, the number that then rescheduled and don't fall foul of this breach, as in it took place now 28 days, that number is going up. So delayed diagnostic tests, delayed cancelled operations because of the knock-on continuing effects of COVID. And why do I say it's the continuing knock-on effects of COVID? Well, this slide, I think, highlights a couple of the key problems here. First of all, obviously, COVID itself, and indeed influenza and other respiratory illnesses, and indeed wider impacts of the pandemic, be there in terms of anxiety or other mental concerns, are leading to a higher level of sickness rates in NHS professionals than we would expect. And this particular slide here just runs up to July 22. And you can see that the sickness rates here in summer are almost as high as they've ever been, and indeed higher than they were in two of the peaks that we had earlier on at the beginning of the pandemic and over the first winter. These numbers undoubtedly have continued to go up. And if you look at the different professions within the NHS, you can see that some professions, actually, those sickness rates are in the region of 10%. But it's not just the sickness rates, it's also the fact that the number of vacancies in the NHS has gone up from actually what was a very good place at the beginning of the pandemic, some of the lowest rates we'd seen for some time, actually since the pandemic have continued to increase and increase. And this concern in terms of sickness and vacancies means that there is less and less opportunity for individuals to actually get the medical care they need, and therefore the impact in terms of mortality. But it's not just the NHS. The one thing I would also add, and maybe this is an area we'll talk about, also in terms of adult social care, the difficulty in getting sufficient staff to run the homes and to look after those leads to a double effect. First of all, it leads to poorer health in the individuals who are in the care homes. It also leads to the effect that individuals who've gone to hospital to be treated cannot so easily go back to either the care homes or indeed to their own homes, and therefore it acts as a continued blocker, if you will, in terms of providing care. And we see that with increasing waits in A&E and increasing waits between A&E admissions. So these are not direct effects of COVID, but they are the continuing effect of the COVID infections we've had in the past and the delays to existing diagnostic tests and operations. And this will continue to act as a heavy driver to slowing any future improvements we may see. Well, I'll pass back to you, Sacha.
Well, thank you very much, Dan. I've got one question before we move on. Just want sort of, and I think I may be able to have detected the answer. How would you assess the relative importance of mortality improvements of endemic COVID, long COVID, and the indirect effects of COVID-19 in the medium term?
I think they have different time perspectives. The likelihood, given what we've seen from the ONS survey of prevalence of symptoms, is that those who are most affected are a relatively, very important, but a relatively small percentage of the population. And therefore the likely driver on mortality improvements would be less. Whereas the number of people who are potentially effectively missing diagnoses, missing interventions is much more significant, and that knock-on effect should be greater. Now, the question is which would resolve more quickly in the longer term. Well, we may get long-term effects because of the very nature of long COVID that could persist many years because of disruption to the cardiovascular system. Whereas when it comes to the diagnostic tests and the interventions being delayed, how long that persists is determined by how long will this continuing problem exist. And I think one thing just to add to that, which is important, is as well as the vacancies we already see, there have been a number of surveys which kind of canvass various different healthcare professionals as to, you know, their views, their attitude, you know, how they feel about the professions in which they work and the situation in which they work. And it's very negative. And so therefore, a very significant change may be necessary to try and get to the situation where we're even having the number of operations and interventions and diagnostic tests that we took for granted prior to the pandemic.
Thank you, Dan. I would like to, at this point, go back to Matthew, but I think we're still having a few technical issues. Hopefully my bespectacled yellow helpers will sort this out in the background, and I'll be able to bring him in at some point. But for the moment, I'm going to bring in Chris, if that's okay, to talk about advances in medical and technology. Chris, over to you.
Hi, so I'm sharing my screen. Hopefully you'll be able to see that. So I'm going to need to be fairly brief, as we've only got 5 minutes, and there's a huge amount of technological advance going on at the moment. So I'm going to focus on those which I think are likely to have the biggest impact. And the first of these is the NHS Genomic Medicine Service. This was launched in 2018 and is expected to become a routine part of care in children. It's still gearing up, but it's well underway. However, it will be used for some rare conditions in adults and specific cancers in adults. And when I say some rare conditions, we're talking about 2,000 to 3,000 different rare conditions and over 200 different cancers in adults. They're also trialing doing whole genomic testing as an adjunct to screening in newborns, and they're aiming to sequence about 100,000 newborns over the next couple of years to see how that can supplement the existing screening programs in children. They're also going to explore the use of liquid biopsies. These are blood tests where you look to see if there's fragments of DNA in it that are indicative of it's usually a cancer. And it specifically, this will be the Grail Gallery blood test. The aim of this service is to improve prevention, treatment selection, acquiring new knowledge. And it's the last of these that's going to be most impactful, because the truth is we still know very little about the genetics of pathology. Whilst this is a huge advance, and we're the first country to be routinely bringing genomic testing into care, its main use at the moment is going to be collecting information that might tell us in the future what patterns of genetic errors are most predictive. So that it's likely to have a significant impact in children in the next 5 to 10 years, but in terms of adults, the effect will be small. But in the longer term, this possibly has the biggest impact. The next thing I wanted to talk about was something called short interfering RNAs. These have been around for a while. The first therapeutic use of short interfering RNAs was in 2010, when it was shown to be able to prevent RSV infection in vulnerable children. But the technology has matured, and essentially what this technology does is it takes tiny little fragments of RNA, and RNA are like copies of DNA that are used to ferry information around the cell, and they take short fragments of RNA and use that to interfere with the transcription of various genes. And you can see the mechanism here. You get a fragment of RNA which combines with some proteins in the cell, and you get this like key-shaped structure which matches a pattern on in the RNA complex that's being transcribed, and switches it off and splits it. And it is actually a part of the immune system. It was only discovered in the 21st century, so we haven't known about it for very long. But we're just seeing launch of really quite large, potentially impactful mature treatments for particularly hypercholesterolemia and hypertension. So these treatments would be an injection, and they might be once every 6 months or so. So one of the big problems with the treatment of hypercholesterolemia and hypertension is actually compliance. People just forget to take them or don't take them for one reason or another. With these injections, you just know they're in there and working for 6 months, and that could have quite a big impact on effectiveness. We do have pretty good treatments for hypertension and hypercholesterolemia. However, possibly a quarter of both of these groups are resistant, and so these treatments will be useful in these groups, and they look pretty effective and have low side effect profiles, and they can be used in other things as well, cancers and diabetes, for example. Other areas of technological advance, robotic surgery is really arriving now, and it looks to have overall lower adverse event rates, and but also interestingly, there's more efficient use of staff. Excuse me. The surgeon actually doesn't have to be in the operating theatre, so there's more efficient use of very highly skilled people. It looks like there may be lower mortality rates, but I think it will take some time before we know whether that's true or whether that's just artifact of healthy selection of subjects. Another emerging treatment, and neither of these are novel now, and these are antibody drug conjugates, where you particularly you take an antibody and you glue a drug to it, and the antibody targets very specifically the target of this drug. And so it's usually cancers, and the monoclonal antibody will attach to a cell surface receptor, be absorbed into the cancer cell. So you pick an antigen that's very specific to the cancer, and then it's absorbed into the cell along with its chemotherapy tail, and it delivers the chemotherapy to the cell that needs killing, but not all the others. So effectively you get the benefits of being able to effectively use much higher doses on the target cancers without causing lots of harm. Regenerative medicine is steadily making progress, particularly around the bioengineering of organs. So there's research going on 3D printing of the frameworks for organs like kidneys and livers, that can then be seeded with stem cells. CAR T, there's a few of these treatments around now, and this is where it's usually cancers again, where you extract some immune cells and then genetically alter them to target the cancer, antigens, very specific antigens on for the cancer, and then re-inject them again into the person. The catch with these is that they are extremely resource heavy, very expensive, and it's, whilst they're very effective, it's hard to see them scaling up, and their use being in anything other than niche areas. We shouldn't take our eye off age retarding treatments, and there's progress still being made there. There's nothing on the horizon really that's likely to have a big impact, but that's not to say it's not coming. There are new pathways being identified, and the particular one of interest at the moment is P38 MAPK, and inhibitors of this pathway seem to downregulate a number of aging related mechanisms, and another is PAPD5 inhibitors. These inhibitors seem to assist the repair of telomeres at the ends of DNA, so there's promise there as well. There are organizational changes that can make a difference, and I think the next few years these may be the major ones to impact, and unfortunately largely negative at the moment, with chronic underfunding of healthcare and a lack of investment in social care, contributing to some of these problems that Dan was talking about. But there, with COVID, it has to be recognised there are potentially some upsides as well, some lessons that have been learnt, in particular the setting up of specialisation hubs. I mean, they did exist before, but they were geared up greatly during the COVID pandemic, and are likely to continue at a larger scale. But also there is a catch-up program in place to try and catch up with the backlog of screening and referrals. And it's hard to believe that when they've done the catching up, that these organizational methods are going to be tossed aside. I think it's likely that we will learn a lot about how to organize and the rapid and efficient delivery of care that may improve efficiency in the future. Now I'll stop there, as I think I've more than used up my time.
No, that's absolutely fine, Chris, and thank you for all that information. I've just got a few follow-up questions, if that's okay. With respect to sort of medical and technical advances, how has your view changed of what you were expecting pre-pandemic?
I think pre-pandemic, things like mRNA therapeutics and vaccines in particular were emerging, but obviously COVID massively accelerated the adoption and application of these new methods, mass development of testing. These are tests are needed as well as treatments, and we're now a lot better at rapidly delivering these. We know that we can deliver them rapidly, whereas before it was very speculative. A year prior to the pandemic, I would have said that the earliest possible launch of a vaccine would have been somewhere around the spring of 2021. And in fact, we had our first vaccination in December of 2020. That's the moon landing equivalent for medicine, really. And now we know we can do that. In other respects, I'm pessimistic about the hangover of the effects of the disease. We know that heart attacks are 2/3 more likely a year after COVID, strokes half again as likely a year after COVID. We don't know how long this is going to last, but it seems likely that we have a scarred couple of generations who are going to carry we may have a new negative cohort, unfortunately, that may carry a higher mortality rate forward with them.
Just sort of finishing on that negative note, let's try and be a bit positive. What is the advance, if you were to think of one advance that you're most excited by over the next 10 to 15 years, what would it be?
In the next 10 to 15 years, the short interfering RNAs. We are now able to switch on and switch off genes at will, really. And with the technology for delivering it has matured, and now it's just a matter of working through the various applications for it. I'm most excited perhaps about the genomic testing, but as mentioned before, I think that's going to have a longer term impact. It's not really going to be the next decade. That it's going to help in the next decade, but it's not going to be a huge leap in mortality improvement at this yet.
Cool, thank you, Chris. For those eagle-eyed, you will have noticed that Matthew unfortunately has not been able to join, which proves you can have all the dress rehearsals you like, but on the night, the stage lighting can still fall off the scaffolding. Unfortunately, I think that Matthew won't be able to join us. What I'll do is just try and briefly do a lack of justice to what Matthew was talking about, just so that the context there. What Matthew was going to talk about was how to sort of think about setting mortality from an expectations approach, particularly in terms of thinking it through from a time horizon. The idea being that trying to think about those catalysts that are most appropriate for each catalyst. So let's say the short term, the medium term, and the long term, and forming an interpretation for each group of catalysts in each time horizon to come up with a conceptually plausible expectation in the future. That is particularly relevant later on when we sort of introduce our scenarios, which are trying to sort of follow that kind of logic, which is a very, very poor way of doing just what Matthew was going to talk about, but hopefully sort of provides that sort of context for what we'll talk about later. To give that probably a little bit more flavour, I'm going to bring in Richard at this stage, who's probably going to give far more just sort of an example that he's been working on to bring together those considerations of longevity catalysts to form an expectation. So, Richard, over to you.
Okay, thanks, Sacha. Yeah, so I should say I'm speaking in my own personal capacity, so any views I express are mine rather than the views of Just. But I thought what it would be useful to do was share quite briefly some of the modelling work we have done recently at Just to try and sort of help us assess the impact of longevity drivers on future mortality rates. And so basically there were sort of two strands to this work. First of all was sort of modelling work where we sort of developed a process to harness expert views on the impact of post-pandemic drivers of change. And we did that by establishing a research group, an internal research group, which consisted of actuaries, epidemiologists, and various other health specialists. But then we also, as part of the second strand, was to make sure the results of that modelling work, the forward-looking view that we got from sort of canvassing experts, was sort of consistent with our sort of analysis of what we're observing in practice in terms of emerging experience. And so, just talking about the first of those two strands, the sort of modelling based on expert views. So this slide illustrates, in a nutshell, what we did to try and sort of model the extent to which pre-pandemic views on future mortality are likely to be shifted by these sort of drivers of change. And so, as a sort of collective group, the first thing that we did was that we identified potential drivers of change, and you can see the sort of a little box in the top left of the slide there shows the sort of the drivers that we sort of used as to sort of categorize sort of potential impacts. Obviously, there's various different ways you could sort of cut this, and different people have used different sort of stratification of the potential drivers. But these are the ones that we sort of came up with. And then what we did is we sort of systematically reviewed research relating to the impact of those drivers of change. By looking at research in the public domain, and also reviewing sort of similar pieces of modelling work that sought to do similar things to us. So particularly sort of work published by actuarial consultancies looking to do sort of similar sort of exercises. As part of this process, we also did our own sort of quantitative analysis of the impact of drivers on mortality. So very much focused on the question of, what impact is this driver likely to have on mortality rates, and trying to sort of look, very specifically at evidence that would help us to answer that question. And we also, we're in a fortunate position to have sort of a variety of different books of business of various kinds in Just, whether it's sort of impaired life annuities, sort of DB pension sort of business, care annuities, smoker annuities, and so on. And this sort of enables us to actually do some investigations of which policyholders were sort of particularly affected during the pandemic at different points in time. Then what we did, once we'd sort of gone through the research, we then sort of went through a process of, we developed a questionnaire that we sent out to all the members of the research group. And the table in the top right of this slide kind of shows the format of the questionnaire. So for each of the 10 drivers that we sort of identified, we got our research group to try and sort of, rather than just sort of say what they thought was most likely to happen in terms of impacts at different points in time in the future, we tried to get them to give us a probability distribution of potential impacts. for each of the drivers. And you can see the numbers in the table there are just sort of notional, but they sort of show the sort of numbers that you might get if there was a driver that sort of diminished in terms of possible impact over time. Then what we did is we had a part of the process where we sort of shared the questionnaire responses, discussed why some people had different views to others, what evidence they'd sort of lent more heavily on, and went through a sort of second round of the questionnaires that sort of reflected those sort of group discussions. And then finally, the final part of the process, which was quite a kind of technical involved part, which was basically to take the probability distributions for each of the drivers and then try and convert them to a sort of an overall aggregate impact for different time horizons. And obviously, in order to do that, we had to sort of make some assumptions about how the drivers were related and how some might be independent, some might be sort of correlated to some extent or another. And I think the useful thing, and you can see there's a sort of an example of the kind of impacts that we were or the kind of results that we were sort of getting out at the end of the process by the chart in the bottom right. I think the sort of useful thing was that it sort of allowed us to sort of see probability distributions of impacts over different time horizons, and I think that was helpful in informing our sort of discussions about how we might sort of allow for this in things like assumption setting. And so, as I mentioned sort of earlier, that was essentially our sort of forward-looking kind of modelling work. We also felt it was really important in terms of consistency to make sure that the results of the model or the model outputs were consistent with what we're actually observing in terms of sort of real-world experience in the kind of the recent past. And I'm sure many of you will be familiar with sort of charts of this kind. This is one where I'm sort of the red bars indicate where we've got sort of excess mortality, so actual deaths are higher than expected deaths since the sort of middle of 2021 for the population of England and Wales. But I think in this particular chart, the expected deaths kind of allow for seasonal variation based on a pre-pandemic sort of pattern of variation. And based on this kind of chart, you can sort of quite clearly see that there's been sort of excess mortality apparent since about sort of spring of this year, quite significant excess mortality, but there appears to be less evidence of excess mortality over the winter, kind of preceding that period. I think what we kind of find is that actually this kind of analysis can be sort of well supplemented by investigations which don't attempt to allow for seasonal variation that's assumed to follow, the same patterns that we observed prior to the pandemic, because basically it seems like the seasonal variation in mortality is now very different to what it was before the pandemic. So in some senses, to use sort of pre-pandemic patterns of variation can be sort of slightly misleading. And actually, if you sort of strip out the adjustments for seasonal variation and just sort of measure excess deaths relative to sort of expected deaths without that kind of adjustment, I think certainly my view is that perhaps gives you a slightly different perspective in terms of the kind of persistency and the degree to which mortality levels now exceed kind of pre-pandemic expected levels of death. And this sort of chart shows that there's been a more sort of consistent pattern of mortality being higher than expected levels once you sort of strip out that seasonal variation. And this is really something that's sort of been a sort of feature of mortality patterns for almost sort of 18 months now. So yeah, as I said, we're very careful to sort of tie the two things together. I think going forwards, actually, we'll be sort of placing even more emphasis on our sort of traditional analysis of emerging experience rather than our sort of forward-looking view. So I think the balance in emphasis will probably sort of move almost like sort of back to placing more emphasis on the sort of traditional analysis of experience as it emerges, because the period since the pandemic is obviously going to sort of grow, or sort of the amount of data is going to sort of grow quite rapidly. That's going to be sort of relevant for us. But yeah, that's all I want to say at this point. I'll stop sharing that.
Cool. Well, thank you very much, Richard, for sharing that. That was very interesting. I had one question I wanted to follow up with was, obviously the advantage, the need in sort of assessing, some of the drivers is to access experts in those effects, and very much those areas where we perhaps as actuaries aren't experts. But that creates a challenge of, those experts themselves will have their own biases. There'll be a range of views, and you can't obviously talk to every expert. So what are the challenges and how do you overcome them in terms of assessing the expertise in the experts, and how reliable that is, and and what are the other challenges that you sort of face when accessing expert opinion?
Well, I think we were, to be honest, I think we're slightly fortunate in that, because of the nature of the business, we already have essentially we have a medical advisory team led by Tim Crayford, and so that team consists of sort of epidemiologists, medical statisticians, public health experts, and so on. So we, to be honest, we lent quite heavily on our sort of internal expertise. We also have, we as a company, we're quite strong in terms of medical underwriting, and so there are sort of we kind of feel that the skill set of medical underwriters is actually sort of quite good in terms of having a kind of medical background, but also understanding what kind of impacts medical conditions have on mortality rates, and so we basically sort of lent quite heavily on those two groups, and and part of that was just because it was sort of readily available to us as a kind of a business. Part of our modelling work was also, we did. It was very interesting to compare essentially the views of the different experts in the panel, and I'm sure anyone that's run this kind of process before, of whether it's to do with this, or whether it's to do with sort of risk models for longevity improvement generally, knows that you tend to get some quite different responses from different experts, and so part of the kind of the judgment is what to do with those different views, and which ones to kind of essentially when you're kind of taking some sort of aggregate view, you don't necessarily just take a straight aggregate of all the kind of results, because some people perhaps have more expertise in other areas than others, and you lean more heavily on some experts than others in particular areas. So part of the sort of judgment is knowing kind of what to do with the range of different responses, and you obviously you do get quite a range. But also we did also find it was useful to go through a sort of stage in the process where we essentially highlighted which people had the most extreme views in relation to particular drivers, and then sort of interrogated them a bit as a group. So why don't you think this is going to have an impact? Everybody else thinks, or the general view was that this is going to be sort of quite impactful in the medium term, the long term. Why do you think it isn't? And that sort of process, I think, helped to understand where people were coming from in some respects.
Cool, thank you. We have had a question in chat that related to the variation from Craig. I think through what you've just said, you've sort of answered that. Sort of there was quite a variation in the final answer. Yes, and Craig's commenting on that, so that's excellent. Okay, so let me just find where we are in terms of our agenda. Okay, so having sort of got those sort of introductory comments on some of the key areas and addressing the key challenges in sort of assessing where at the moment, we're going to sort of move on to discuss our expectations for the future. And to facilitate this, we have created 4 scenarios of improvement, and I shall try and pop those onto the screen now. So I'm hoping that they're written in real world enough terms that they're relatively straightforward. But while you're reading those, I just want to make a few comments. we've created these purely for the purpose of this webinar, so we can frame the outcomes for you at home and for our panelists. So we're talking about some real concrete examples of scenarios rather than sort of the general idea. And whilst they are in some sense intended to be realistic and cover the range, they should not be viewed in any way as official IFWA or MRSC guidance. They are not definitely not the outputs of the kind of process that Richard was talking about. They are, in a very real sense, lines on a chart. So if I just move on to the next slide, you can see exactly what I mean by that. And I'll just to bring these to life a bit more, we've shown these in terms of standardized mortality improvements. So you can see the historic period on the left, including the COVID period, a smooth version of what that looked like over 19 years prior to 2020. And then each of these scenarios envisages a pattern of improvements in the future. So you can see for sort of medical breakthrough, we're envisaging, sort of something occurring over the next 5-6 years that significantly improves health outcomes. So we see mortality improvements rise quite rapidly, but then reduce. We've got, the effects, if the government chose to do so, through levelling up or otherwise reversion of austerity. So mortality improvements rise over the next 20 years. We've got a more stagnant view scenario whereby mortality improvements are quite low, if non-existent, coming out of the pandemic, but do rise over time as the effects of COVID-19 subside under that scenario. And then finally, the most pessimistic scenario is a sort of end of improvements, where we come out of the COVID-19 pandemic in negative levels of improvements, and then either nothing much happens or anything positive is offset by anything negative. And possibly, in this sort of references the point, is quite useful in terms of thinking about the sense of these, is to consider sort of the short, the medium, and long term, to consider the likelihood of the catalysts that will drive these. So once again, just going to caveat, these are very much lines on a page. They are not anyone's particular view. They're just, in some sense, covering the range to allow a view. Okie dokie. So hopefully that's relatively clear and provides somewhat of introduction, so I can move on to sort of really put our panelists on the spot, if that's okay. And I will start, I think, in the order of the speakers with Dan. And I'm going to ask this question to each of you in turn. But Dan, what's your view of longevity catalysts, past, current, or future? Which of those catalysts do you see as being most critical in assessing the future pattern of mortality improvement?
It's a very very deep question, and I guess one that maybe we didn't cover quite so much during the previous conversation was in respect, and it relates to a question that's coming from Adele, which is, we talked a lot about, potentially these shortages in terms of global workforce of healthcare professionals. And the question is, what could you do more with the workforce you already have? And one of the advantages that Chris was alluding to during the pandemic was the increasing use of remote technology, both to connect between patient and doctor, but also to monitor. And so I guess the catalyst that I probably would see having one of the greatest potential impacts going forward would be the use of remote technology to monitor individuals' health and to pick up either early signs or good management of disease going forward. And the speed with which that is rolled out could have a very significant impact in terms of people's health. We are already seeing a significant benefit when it comes to areas like psychology, where remote technology and indeed use of VR amplifies the number of physicians that we have. The speed with which this actually happens in other domains, I think, is going to be very important.
Thanks, Dan. Chris, what about you? Which catalyst do you see most critical of forming a view on in terms of future patterns?
I'm somewhat pessimistic, and I don't think these different scenarios are less necessarily entirely mutually exclusive. I think that we are going to see stagnation in improvement, partly because that's the pattern that's being projected towards us at the moment because of the recent past, partly because of the economic strains on the system, but also because of these, the remaining impacts of COVID. However, investment in medical technology is pretty inelastic, and so it's likely that investment in medical technological advances is going to continue, and to a degree mitigate that. So if we're looking at the pink, I think the most likely scenario is somewhere between that pink and the brown trajectory. Who knows where? But that's I think that's the most likely scenario.
Thank you. That's great, Richard. Before I sort of ask you to sort of come on to talk about the scenarios, especially thinking back to the thinking you've done, which longevity catalyst do you see as being most critical in assessing the future pattern?
In terms of sort of the future pattern, well, in terms of those scenarios, anyway, I'm also quite drawn to improvement stagnation, in the sense that it seems quite likely that, say in about 2025, that mortality rates could be quite similar to the kind of level that we had prior to the pandemic. So maybe sort of 2019 mortality rates. And so in some senses that you could interpret that as being, implying stagnation. Obviously in between, we've had this sort of period when sort of rates have obviously gone up a lot, and are probably likely to sort of come down. But as I said, I think they'll probably just come down to, the most likely outcome is they probably sort of come down to about the level that they were prior to the pandemic by about 2025. But really sort of big question is, that's definitely not certain, and it could well be that we have higher mortality rates than that, and therefore sort of negative improvements that are sort of more in line with the sort of the sort of the green line that you've got there in the very short term. And there are a number of the catalysts which will determine that are things like how quickly do sort of deaths with an underlying cause of COVID are sort of reduced over the course of this year. But how will that sort of continue in the next 2 or 3 years, or will we continue to see a small percentage of deaths with COVID as an underlying cause? I think it's currently about 3% second half of this year. How quickly will that sort of reduce with time? And then there are other sort of drivers as well. How Dan and Chris have sort of referred to some of the research showing that cardiovascular mortality is sort of elevated following COVID infection, but how strong an effect is that, and how sort of persistent is that going to be over the next sort of few years, and that will determine again sort of how quickly mortality rates sort of reduce from 2022 levels. And then also I think the other sort of driver that I think is really important in the short term is the sort of the health service disruption that particularly Dan showed some of the evidence for, and so that's really going to be a very important sort of catalyst in terms of driving what we see in the short term, but probably also the sort of the medium term as well. Then sort of I kind of guess looking further forwards, once we sort of shift into the sort of medium term and long term, I think that's when the sort of the sort of the economic factors, as well as the sort of some of the sort of demographic pressures on healthcare demand start to be the sort of the most important catalysts. So I think it's sort of, yeah, which of the important catalysts sort of shifts a bit as we sort of move forward.
Excellent, thank you. Dan, can I bring you in at this point to sort of give your thoughts on sort of the relative likelihood of these alternative scenarios?
Yeah, no, absolutely. And I was just looking at the kind of the past, the blue line, and kind of reflecting on, you know, where those actual improvements came from. And I think, you know, going to Chris's, you know, excellent exposition of where potential technology developments may come from, there's a big difference there, which is in the past it was, you know, the rollout of relatively inexpensive or relatively accessible changes to overall delivery of care that led to significant improvements, you know, whether it's kind of the impact on blood pressure, reduction in smoking, and improvements in coronary heart care. And going forward, you end up with a smaller number of areas which could have a significant impact, such as the mRNA developments that Chris was describing. But as yet, they're relatively unproven in wider areas. And so I think I would be more tending towards kind of the kind of improvement stagnation going forward for a couple of reasons. The first is I think these longer term effects of, you know, COVID and the difficulties with healthcare delivery. I mean, I think they'll act as a considerable drag for some time, maybe below the levels of the improvement stagnation. But over some period of time, then the emergence of some of these game-changing views in the way we deliver care and the way we monitor the success of care, I think then potentially pulls up the improvements. The one thing that I don't think we've talked about at all yet is this may be the line of improvements that applies to a significant portion of the population, but I do see going forward a very high likelihood of increasing divergence around that central line where access to care or likelihood or ability to make behavioral changes means that you're more likely to be up or lower compared to that central line. I think that's going to be a bigger issue than we've ever seen in the past in the UK, for some time at least. I guess I probably struggle to see that there's a likely path, given where we are today, of getting all the way up to the kind of the medical breakthrough type improvements. Similarly, as Richard was saying, I do think the next couple of years are going to be very, very difficult indeed. And so mortality may bump along where we are or go down slightly. The important thing for me is, when will we have clear enough markers as to which trajectory we're going to take? And what's been very noticeable, particularly even in the informed debate, has been that we seem to be highlighting in our discussions developments which are further off in the future than we historically would have considered in the past. And whether that's just, you know, people like to have something positive to talk about, or whether that's a genuine dearth in the way of developments, I do think that there were a wider number of different possible improvements that were discussed previously, rather than having to go for the more Hail Marys. I mean, Chris is absolutely right. The rapid moonshot of what mRNA was able to do for vaccines and the potential wider application is very much a development. But we should not forget there's a significant proportion of the population who have a major problem with the use of mRNA for vaccines, or indeed other pieces. So there is a very strong behavioural element here going forward, which similarly we've probably not experienced in the past.
Yeah, that's a really good point. Let me sort of bring both Chris and Richard in on that one, and sort of, rather than just sort of going straight back to you on that one, Dan. Is when do you think we'll know what sort of trajectory? I'm not saying that these are the only four possibility, but what timescales are each of you envisaging it will take before sort of the world becomes clearer, if at all? We may be sort of in for 10, 15 years of extreme uncertainty and but what's the minimum timescale you're envisaging it will take?
For uncertainty to emerge, I mean, to some degree, that's a statistical question. But also, we're talking about the development of endemic. I mean, we are still in exit waves of COVID, and it might be 5 years before we're in a steady state. I suspect there'll be some evolving of not just the COVID, but the population's response to COVID over that time as well. Hopefully, with less severe and less low mortality rates. But 5 years might. I think in 5 years we should have a pretty good idea.
Richard, what do you think?
Well, I suppose if I sort of look back and kind of remember what I've thought at different points, sort of since the start of the pandemic, I've always kind of felt that, if we just had 3 months more data, or in 6 months' time, we'll have a much clearer view about what's going to happen, or in a year's time, we'll be much more sort of certain about what's, and it seems like that's that. I still probably think that. I still think, with another year's data, we're going to be in a much stronger position in terms of knowing how mortality is sort of behaving, sort of in the kind of post-pandemic period. But that's probably wrong. I think we're still in a year's time. We'll still be thinking that another year's data will be helpful. I think. So I don't think we're necessarily going to get to a position where we gain any sort of massive certainty anytime soon.
And I think some of that
quite a kind of period of extra data that we'll need.
And picking up on a point that Dan was making that relates to this really is the inequalities. The likelihood is that this is going to expand the inequalities in mortality rates. We know the most vulnerable members of society are those who are most affected and most afflicted. So they are, they're going to be overrepresented in this sort of cohort of vulnerable people. That's important to this industry, of course. How's it going to segment between the relatively well-off, well-educated segment of society who dominate in insurance products and pension liabilities versus those, and that will take a lot of data. I think that will take a good 5 years to see how get a stable view of how inequalities have been affected and how that then affects this industry. Because I would agree, it's by no means implausible that we'll have negative mortality improvement rates in the next 3 years. But that's across the population. Much less likely in the insured and pensioned population.
Dan, do you concur with sort of Richard and Chris, or do you have a slightly different view on the timescales?
No, I think I would concur with them. The one thing I would say is that it goes to kind of Richard's point, which is that in the past, when we said we wanted 3 months data, that then it was just a kind of expression of a period of time. For me, the difference now is 3 months of data is 3 months of a variety of studies which were never carried out before, or certainly weren't published and presented to people in the level of detail. And indeed, as we're seeing in MRSC, the opportunity to actually investigate some of those data sets. And I think that difference is very key when it comes to Chris's point of trying to understand how different segments within society have been affected and the likelihood of it improving. It also adds an additional pressure, if you will, to governments and to kind of overarching organizations, that it's much more apparent at a quicker, earlier stage when there are problems. The fact that in the UK we are able to see a lot of metrics relating to health delivery at a kind of quite a local level, and also to see it broken down by age, sex, and other characteristics, I think means that those 3 months of data actually provides a lot more depth than, say, 3 months in the pre-pandemic period when those databases really hadn't been constructed and brought to bear. So I think 3 months now is worth more, but at the end of the day, there is still this issue that, in general, the actual profession does not have access to quite the quality of data that those working in either academia or the healthcare sector directly do. And therefore, going to Richard's original point, it's not just talking to an expert because they have a particular perspective, it's also talking to the data scientists because they have the ability to examine data, which may not be possible for insurers, reinsurers, consultancies.
Yeah, absolutely. Okay, going to bring in a question from the audience. We had one from Vicky. How do you think these different scenarios will affect different parts of the population, e.g. old or young, bearing in mind that these are age standardized, and the affluent and deprived? And I think we've hinted at the latter. Who would like to try and tackle that question?
So I've stated my view on the affluent, deprived. I think the affluent are going to be a lot better off than the deprived. For the young and old, it's older age groups who've had COVID and survived that are going to carry this vulnerability forward more than the young people. So I think that, I wouldn't be surprised if we see a cohort emerge, a negative cohort emerge in people 50 to 80.
Although I suppose having said that, if you look at recent experience on in terms of how actual deaths have compared to expected deaths by age, there's perhaps evidence that the impacts are kind of slightly higher at younger ages or younger adults compared to older adults. So I suppose there is a sort of there is a school of thought that actually there may be a sort of a bigger impact which is more persistent in terms of the indirect impact at sort of younger ages. Thinking of things like the mental health impact of the sort of pandemic on younger populations, and how that will affect people over time. So I suppose there are it could go in different directions.
Okay, thank you. Just on the thinking about the most affluent deprived, I mean, there was, at least pre-pandemic, and I think there still is now, quite a lot of excitement in what is called the longevity industry, with respect to anti-agapics, age reversing, etc., etc. And the likelihood is, if they came to pass, that they would be more accessible to the most affluent. I mean, Chris is probably a question for you, and I'll bring in Richard and Dan in separately. How confident are you that these will prove to be significant enough to sort of move the dial now?
I'm reasonably confident that we will have at some point, not reversal of aging, but slowing down of interventions that slow down aging over the next few decades, not really in the next 10, but perhaps after that. We need to bear in mind that we know some of these already, like not smoking and exercising. These things actually work. So I suppose we should focus on pharmacological interventions, and there are candidates for that. Aspirin, metformin, statins, perhaps play a part. But then we have these new aging pathways that are being, I mean, they're incredibly complicated, but they are being elucidated and are going to give us potential handles for slowing down aging. The main worry is the unintended effect. So we talked about telomere repair. I mean, there's a reason telomeres degrade and disappear, and that's because it probably stops cancer. So there's always this fear at the back of people's minds that you might slow down aging a bit, but just kill more people with cancer, which might seem a poor trade to many. But if you were to ask me, in 2050, will we have seen any interventions that slow down aging? I'd say, well, yeah, we already know some, like exercising, but widespread adoption of some pharmacological interventions is quite plausible, I think.
Richard, Dan, anything you'd like to add further on anti-agapics?
I suppose Chris is more of an expert in this area than me, but I just think I think it's sort of interesting that if you'd have asked somebody the same question 25 years ago, if anything, they might have actually been slightly more optimistic about the potential for anti-aging sort of treatments sort of coming on tap. Now people are sort of talking about the same kind of possibilities, but are perhaps a bit more realistic about how long they might actually take to sort of develop in practice, or some of the sort of the difficulties that in terms of the sort of the practical implementation of anti-aging research.
And I think we need to bear in mind the perspective as well. I mean, Aubrey de Grey, someone alive who's going to live to 1,000, no. But if there are interventions that just reduce, these are potentially marginal benefits that have quite significant effects in pathology. For example, if you can reduce inflammation, you reduce various pathologies related to chronic inflammation, these aren't going to result in people living forever or even 200 years, but may extend a healthy life expectancy quite significantly and contribute to mortality improvement quite significantly. But it's all very uncertain. I
think one thing I'd probably add to what Chris and Richard have put forward is that, and this is one of the big challenges we've had with public health up to now, is there is always a tendency to regard everyone as being quote unquote starting from a similar position, and then you make the intervention that we would intend for the average person, and the hope that it would impact. And I think one of the things that's come out, whether we're able to get to the point of slowing aging, we definitely are likely to be at the point of being able to detect disease much earlier, which seems very odd to say, given at the moment we've got actually less people coming forward to go for their regular screens and their health checks, etc. But the ability to not only have a better sense of the onset of disease, but also to have a view of your functional health status. And when I say you, I don't just mean the individual, it's also the interactions we now know with all the omics, the better understanding of the microbiome, the better understanding of when particular genes switch on and off and what that means. That type of information could lead to new recommendations within public health and indeed within kind of primary care, which would act as a nudge, if you will, to maintaining health for longer. And I think that kind of, at some point it has to happen where we move from curative medicine through preventative to actually restorative. And that kind of approach is now more likely. It's just very weird because exactly the time where we can see that path more clearly, many are actually going the opposite direction, and they're gathering less information about their health, or they're paying less attention to the kind of signals there might be with reducing exercise and maybe eating and drinking more than we should. So, which obviously is very topical as we go into Christmas. But I do think that is a step before we get down the route of kind of actually manipulating our health to actually being more aware of our functional health status.
Yeah, and I think to some degree it's a false dichotomy to say, age retarding treatments. I mean, we need to probably think of them as reducing the incidence rate of age-related chronic illness. I mean, that's the way. In 50 years' time, that will be the way we'll be looking at it. Is that we'll have made big improvements in reducing respiratory disease, chronic kidney disease, cardiovascular disease, postponing it. But we'll be seeing it as postponement of those diseases rather than, age, an influence on the aging process, because they're a bit, they're a bit inseparable, really.
Well, switching to the other end of the socioeconomic scale, we've had a question from Philip, and just asking whether anyone has any views on the medium to long-term effects of the rise of obesity.
Yeah, I mean, it's obviously not it's not great, and the rates of diabetes in younger generations are kind of scary. So I mean, in terms of the potential impact and how it affects different generations, and which scenario is most likely to sort of play out, I suppose that's certainly kind of one of the factors that would make me a lot more pessimistic about what's going to happen to younger generations as they sort of age in the future. So yeah, it's definitely makes me sort of think that the scenarios are probably going to be different for different generations, and not in a good way for the sort of the post-war generations.
Chris, Dan, would you? So go on, Chris.
I mean, I'm putting on my devil's advocate hat, so take what I say with a pinch of salt. But we could view this more as a shift in the distribution, where the distribution of weights has shifted upwards. Now, in many ways, being underweight is far worse than being overweight. Yes, there's links between hypertension and diabetes and obesity, and more recently, you're much more likely to be affected adversely by COVID, for example. However, we may have seen a shift in upwards in a group of people who are previously malnourished. So the net effect overall might not have been that negative, but it is negative for that tail at the top, to be sure.
I mean, one thing that's very interesting in this is, the biodiversity of our diet, if you will, and the extent to which we are increasingly dependent on a very few numbers of crops, and we're also very dependent on sometimes very processed versions of those, and therefore, there's a political dimension to this as well. And indeed a dimension that links to kind of climate, which is, what will be the food that's available in the future, and how will that potentially lead to different patterns in obesity, in the same way that we've seen throughout history, different instances of decisions relating to diet that have had huge impact, whether it's kind of moving from the brown rice to the polished white rice in China, and generally increased kind of levels of meat intake for country after country. So I think the difference now compared to the past is the belief that there are a number of, should we say, either interventionist or shorter fixes that kind of try and get around this or try and prevent it, playing around with kind of hormones like ghrelin, etc., compared to actually the fundamental underpinning of what is actually the relationship between ourselves, our diet, and the countless trillions of bacteria that we're carrying around, that actually probably make us quite interested in a variety of foodstuffs in the first place. So what I'm looking forward to is, once again, more data which highlights actually the implications of our dietary choices, and once again how public health can work in a positive sense to influence and inform, rather than lots of pictures as you go down on the underground saying, this is how you look, do this easy thing, this is how you will look. I think that kind of dynamic interaction with regards to public health is something that hopefully is going to develop much more strongly as we move into a stronger information age.
Thank you. I think one thing we haven't touched on, or at least not to a great extent, and probably should do, is Alzheimer's dementia. I mean, there was the announcement a few weeks ago about some level of breakthrough, and I think it's sort of important for us to sort of just ask is, what are your levels of optimism about sort of, treatments, be they prevention, direct, or just better ways of treating people with Alzheimer's dementia to actually sort of improve mortality outcomes for people with Alzheimer's, or preventing them from getting Alzheimer's dementia. Does anyone want to have an attempt at tackling that one? Go on, Chris.
Okay. To be sure, this is a breakthrough in that it demonstrates, it's the first time we've actually demonstrated a change in the natural history of dementia. I mean, there have been treatments in the past which are, largely, twiddling around the edges, but unfortunately didn't have any impact on progression. This is the first time that we have managed to slow down progression, and whilst it was modest, this is just the first one. It's a proof of concept. There were, increasing doubts as to whether, beta, to the target of beta amyloid was the correct target for the pharmaceuticals industry. We now know it is a good target, and so it's likely to lead to other innovations with a greater effect size, I think.
The only thing I'd add, I agree with Chris, but the only thing I would add is that we probably need to somehow have a more kind of balanced debate in the wider discussion when it comes to new drugs and side effects, etc. When we're talking about something like these treatments, which have a very profound effect on particular molecules within your brain, then there are likely to be effects, and therefore it's trying to view the overall benefit in a considered way, rather than assuming that that there are kind of wonderful cures that are just around the corner that we can easily pull out. I think the one thing I would say about the mRNA vaccine is it perhaps has led to some unrealistic expectations as to how progress is made. It certainly kind of opens some ideas as to what might be possible, but we need to be balanced. And the important thing is that the process that is well established of these long clinical trials that test out the variety of different safety issues and test out the optimum dosage, that is absolutely key, and people must have trust in that it's being well done, rather than a process which kind of people are kind of saying, oh, it needs to be rushed out, or it needs to be done this. Having the process, given that these are treatments which have a potentially very profound impact on particular parts of our body's infrastructure that we don't fully understand as well as we would like, and therefore let's go through the process correctly. I appreciate for those people who already have these conditions, that's probably not the message that they always want to hear, but we need to take the societal perspective here, which is that over time, we're hoping that these type of treatments and others like them would have a profound impact over the longer term that you kind of illustrate here with your scenarios, and rushing it does not help.
I think time-wise, I think we're going to have to draw it to a close. We can obviously continue for many, many hours to come, because the complexity and challenges is no way diminishing. So I'd like to thank the panelists for both sharing their time, expertise, and indeed their insights. Thank you for sort of offering your opinions and sharing with, with the audience. That's been great. I'd also like to sort of highlight sort of the work done by Caroline Roberts and Martin McGuigan, who are members of the management committee of the Mortality and Longevity Member Interest Group, for their support in preparing for this webinar. Thank you very much, guys. And I'd like to thank you at home for joining. I hope you found these discussions useful and interesting. We will be continuing the webinar series in 2023. The next one will be advertised shortly. But if you have got any suggestions for topics you'd like us to explore, then please get in touch via the webpage or LinkedIn. And the only thing that remains for me to say is I hope you have a good time managing your longevity risk over the next few weeks, and we'll see you in the new year. Thank you very much. Goodbye.
Thank you.